Hello, welcome to the webinar on Innovations in Integrated Care, How to Adopt Lessons from Spain for the United States. My name is Richard Scheffler. I'm a professor of health economics and public policy at the University of California, Berkeley, and I'll be administering this webinar. The webinar will involve presentations from our study team from Spain, and also leading academics, as well as representatives from the Medicare program in Washington, and a leading member of the leading person who runs a Medicaid program from the state of Washington. The project has been funded by the Robert Wood Johnson Foundation, and this is the culmination of 2 years of effort in studying integrated care in Spain. The study team has made 2 visits to Spain, and we have initiated work in 3 regions of the country. One of them is in the Basque region, the second region is Catalonia, and the third region is Madrid. And you will hear the lessons we've learned from looking at different models of integrated care in Spain, and we'll pay particular attention to any of the lessons we can bring back to the United States and possibly for other healthcare systems as well. So I hope you have an enjoyable time, and our first speaker will give you an overview of the general findings of our study and the lessons learned to date.
Hello, good afternoon. My name is Nuria Mas, and I'm a professor of economics at IESC Business School, and I'm also the holder of the Jaime Grego Chair in Healthcare Management. Today, I will talk about the overview of Spanish innovation, individual and community care plans, integration in emergency care, and in social and health care. I wanted to say first that this is joint work together we have a Spanish team. I'm from the Catalan region, and most of my research is in the Catalan region, but we have also worked together with Ana Miquel from Madrid and Roberto Nuno from the Basque Country. So most of the things that I'm going to say would apply to the 3 regions as well. First of all, I wanted to think for a second about the fact that we are all sharing very similar problems in the US and also in Europe. We face an aging population, and when we design our healthcare systems, basically they were designed to provide solutions to a population that was mostly suffering from acute care. Now our needs are very different, and we are all trying to figure out what's the best way of taking care of this increasing aging population that has a lot of chronic care needs. But we are doing that in a context where the socioeconomic realities are very different. We have areas like the ones that you see in these maps. This is the map of Catalonia. So we have to provide answers in areas where there are a lot of poor people, maybe, some of them in rural areas, where the children have left home, and basically we are facing an aging population that is mostly living alone. This is very different from an urban population. So we have to find a model that would help us provide these integrated care solutions to all these diverse realities. Another thing that we have to take into account that would refer to the map that you see on your right is that the structure of the providers of healthcare is also very different. So we have rural areas, urban realities, some of them with very advanced hospitals, some also with some lower level hospitals, some with no hospital at all. And whatever model we think of has to be flexible enough so that it can provide the answers to all these different realities. And this is precisely what the different areas in Spain have been trying to do at different moments in time. In particular, the Catalan area, the one around Barcelona, designed a healthcare plan in 2011 and 2015 that basically one of the pillars that it had was to provide better care for the chronic patients. And out of this, they developed two programs. The first program, it's the PPAC, the Program of Prevention and Attention to Chronicity. This program was basically including the integration or considering the integration of the different levels of care, emergency care, primary care, hospital care. But after a while, they realized that actually if you ignore social care, you are missing very important parts of the issue. Because when we are talking about chronic care patients, especially those with comorbidities, the social component is going to be crucial. And that's why a few years after developing this PPAC program, they developed a new one, which is the Integrated Health and Social Plan. So I'm going to be talking a little bit about both of them. Now, the crucial aspect of this program is that what matters is to have an integrated vision of the patient. What we want to do is to think completely in a different way about what's ailing the patient. We are not looking at the care solution. We are trying to look at the solution for the patient throughout all his or her reality. Because when you have a chronic care patient, the fact that this one is living with a partner that is absolutely healthy really makes a huge difference from this patient, the same type of patient living alone, for example, far away from a hospital. So including all these elements is going to be crucial. And for that, what we are doing, what the Catalan system did, was to think about this in a care pathway format. The goals of this program were first to obtain the best possible care for the population. That's the key goal. Every local area will try to organize its resources in the way in which it can help as much as possible to achieve this care for the population. The second thing is a proactive plan. So basically, the idea is to anticipate the needs of the patient and to identify as soon as possible these patients that have chronic care needs. And when I say proactive, you will see in a few slides how important that is. These patients don't have to come to the healthcare center to be identified. The system will be looking for them, so that then, once you found them, you can think about this completely different way of providing care in an integrated and global, holistic perspective. And the third objective is efficiency. So to use the available resources in the best possible way. To do that, we have 4 key enablers of success in our criteria. The first one is the identification of the population. The first thing that we need to do is to find these patients that have these special needs. I will tell you more about each one of these elements shortly. The second thing that we need to do is once we've identified them, we need to share this information. People need to know about that. And when I say people, I mean the different types of providers that we have in the system. Because if what you want to do is to have a patient-centric approach, we need to develop different programs for each one of these patients. We need to really personalize that, and that cannot be done if we don't know this information. So sharing it is going to be crucial. The third element is this shared individual intervention plan. As I have just said, when you design a personalized care, when you think about the person and you think about what this person needs, but also which are her preferences and her values, you need to design a different plan for each patient. And this is what the Catalan and also the Basque and the Madrid system have been doing. And finally, the weight of local agreements. I will tell you more about them, but basically most of this care is organized locally. The local providers will reach an agreement between each other so that they can achieve these three goals while taking into account the different needs and realities of the territory. Basically, the first thing that we need to do then is to focus on this types of patients that need it the most in this case. And this is the characteristics of the population in one of the regions in Catalonia, and this is population older than 50. So we see 33% of them are absolutely healthy. Then most of them are not complex chronic patients, but we have a bulk of 3.5% that are complex chronic patients, and 1.5 that are advanced chronic patients. These advanced chronic patients are the ones that also have a life expectancy of about 1 year. So basically, there will be about 5% of the patients in the territory that need to be identified so that then we can start implementing these different elements. So let me tell you a little bit first about the identification of the target population. We have these two groups of patients, and I've said that this identification is the first step, and I would like to highlight 3 elements of this identification that we share across regions in Spain. So the first one is that it's proactive. The different providers of the healthcare system can identify these patients at any point in the delivery process. It doesn't need to be only the primary care team. It can be anybody, including the social worker. Now, the primary care team, it's the one in charge of labeling these patients as patients with chronic conditions or patients with palliative care needs. But basically, the identification can come proactively from anywhere. And actually, one of the things that was communicated to the different local teams was, according to the characteristics of your region, you should have about, let's say, 5% of the population belonging to one of these 2 teams. Find them. Where are they? We have to find these patients. So the first one is that it's proactive. The second one, the second characteristic that I think it's relevant is that, of course, in any labeling, there's an algorithm that will help the decision makers, the providers, to identify this type of patients, and that's obviously based on evidence-based characteristics. But the element that I think is differential is the fact that basically the clinical judgment will prevail. The primary care doctor has the final word. So you can add different other elements that maybe the algorithm would not be taking into account. So once the patients have been identified proactively, then the other characteristic that I think it's very important is that this labeling is communicated to the patient and the family so that they know. And then if they need some type of treatment, they can communicate their condition, their labeling, to the different type of providers. So these for me are some key characteristics of the system. Then this labeling can be seen in many different platforms. It's very important that, as we have said, everybody in the system knows about this condition. And this is what providers, physicians, specialists can see when they enter into the shared clinical records of the patient. What you see on the right, this round yellow circle, it's basically the identification of a patient as either a complex chronic patient or as a patient with palliative needs. So this is something that everybody in the system would recognize, and then they can act accordingly. So first I've talked about the identification and the labeling. Then the second enabler of success that I think is also quite differential is this shared individual intervention plan. Once the patient has been identified, there will be a plan that is going to be worked out together with the patient. So the patient and the family will be an important part of this design of the plan. And this intervention plan includes directive what to do in situations where the patient is stable. And there the goal basically will be to keep the patient stable for as long as possible. And then there will also be indications of what to do when the patient has a healthcare crisis. So some characteristics of this shared individual intervention plan. First, it's personalized. It's different for every patient, and it also takes into account all the patient's social characteristics. It's not the same, again, a patient that lives on his own than a patient that lives with a partner. It's not the same a patient that has the family, the children close than a patient that has the children far away. All this will be incorporated in the design of this shared individual intervention plan. Another aspect that it's, I think, very important is that this shared individual intervention plan doesn't only take into account the healthcare needs, but also the preferences and the values of the patient. And that's going to be extremely relevant, especially if we are thinking about advanced directives. A patient that is really sick might prefer to be treated at home than at the hospital. And this is something that will appear in this individual intervention plan. And this is also something that the primary care doctor or the case management nurse would have discussed, not only with the patient, but also with his or her family. Because in many cases, the families are a very, very important part of what's happening to the patient, especially if the patient has palliative care needs. So this care plan, it's elaborated together, as I was saying, with the primary care doctor, but also with many more members of the team. In one of the areas that we visited in Catalonia, the social worker was very heavily involved in the design of this plan. Actually, the area that we visited had a social worker, that it's a municipality worker, that was literally placed or working exactly in the same building and in the entrance of where the primary care patient is, where the primary care physician is. Okay, so basically this plan is elaborated in consensus and collaboratively with many providers in the sector. And that makes it very powerful, because basically everybody that will have to then respond and take care of this patient at any level, primary care, social care, or specialist care, will be involved in the program, apart from obviously the patient and the family. Then another thing that I think makes it very useful is that, of course, this is a dynamic document, because the realities of the patient change. So then, if the reality of the patient changes, the document needs to change accordingly. Let me give you just a real example. So there was this chronic care patient. She was not advanced. She was living with her husband, and she had different chronic care ailments. But then the husband died, and the kids, her children, moved to live in another city in just 1 month different, just because life took them there. So then the situation of this patient, even though clinically maybe had not changed that much, socially had changed enormously. And actually this would require a completely different type of intervention plan in case of crisis, and also maybe during the stable situation. So the program, the individual plan, was changed accordingly. It's important then that it has this this dynamic aspect to this. And then once the plan is elaborated, it's decided, and it's consensuated, it can be found by all the different levels of providers in the shared clinical record, in the shared medical record. That's what will enable everybody to know about it, even though the family knows and the patient knows, and you can communicate it to any of the providers. It's important that, of course, they have access to the plan. So this plan, as I was saying, can provide paths of care in situations where the patient is stable, and also during crisis. When the patient is stable, for example, it has information as important as where's the contact phone? If something happens, who do I have to call? Who is the daughter, the son, the home care worker, somebody? We need all these contact phones. It seems to be, something very easy, but not that many people, not that many plans know exactly to whom to call. So that's an important element. There's also the relationship of the contact. It can be the case management nurse or the primary care physician in different localities, in different territories. The contact or the reference person might change. In some are nurses, in some are physicians, in some might even be social workers. Then there's some revision of the medication, and then the proposed follow-up services. So it might be, a reminder of the patient needing to see the doctor after a few months, and so on. Now, during the crisis, there are two different paths. One, for the usual working hours of the primary care center, it's usually preferred, and that's encouraged, to try to take care of the patient at the primary care location as many times as possible, and sometimes even at home. During non-working hours, then we have a hotline, a phone hotline, the 061 in Catalonia, or the 112 in Europe. 112 also would work in Catalonia as well, actually. But basically, we have a hotline where these patients can report these healthcare needs. I will tell you a little bit more about that in a second. So, which type of information does this personalized plan include? As I was saying, it was telling you about, what to do in crisis, advanced care planning, social services utilization, and also social service feedback. So look at that. We are sharing information from the social services and healthcare. And that's, I think, quite unique. And that's what I think makes this chronic care pathway so useful. Because if you are missing one of these components, you are really not providing the best possible care to the patient. Then we also have information on the diagnosis, the medication, allergies, and all type of data of what to do in types of crisis, etc. We also have information on the phones on whether this patient is living alone or not, whether he has telecare, etc. All types of social elements. So let me tell you a little bit about the emergency care and the response during crisis. One of the things that I was trying to convey to you is how important that is, that once we look at the care of the patient, all the providers are in it together. And that's a very strong feeling. And that requires also the emergency care to be in it together with the rest of the providers. It's not a different part. It's part of the whole care pathway. Now, what happens? What does this thing translate into? Well, there's this hot line, this phone number where everybody can call. We have that in the Basque Country. We have that in Madrid. We have that in Catalonia. The patients can call there. And this number will direct their needs. What's interesting is to keep in mind that the people that would be taking this call, apart from having the usual protocols of answering in emergency crisis, they also can see whether this, once you have, because what they ask from you, it's what's your healthcare number. Okay, so one of the things that they can see there without seeing any other information is whether you have been labeled as one of these two particular types of patients. Okay, and with that, they would respond accordingly. In this call center, apart from the people that would pick, usually administrative that would pick up the phone, we also have working there nurses and doctors. Depending on what's the situation of the call, this call will be transferred to a doctor or a nurse, again, following the protocol. And these doctors and nurses will be able to access the clinical record. Not all the information will be available to everybody. Obviously, there will be some data protection issues that are very relevant, of course, but they will know about this patient and see how important that is. Because if you have to respond to an emergency call where a patient has the directive of not willing to go to a hospital, you have to respond very differently than if the patient really wants to be taken to the hospital. That's just an example. But it's very important that we can see the advanced directives, and it's also very important that you can see this pathway, because the emergency care, it's an integral part of the designing of the care pathway, the response that we said in stable situations, and in particular in this case, in emergency situations. They act, they intervene, providing feedback, they intervene being part of the solution. So basically, most of the responses that they provide are of working hours, as I was mentioning before. And once the patient has called, once the patient has been evaluated properly by a doctor or a nurse, then there are 5 levels of response. Level number 1 has to do with the patient being taken immediately to the hospital. Level number 5 is I will answer it just by the phone. And of course, in between, we have this patient being taken, for example, to mid-complexity hospital, or the patient being taken care at home, sending an quickly clinical ambulance, for example, or sending somebody in the team home, but maybe with a little bit more time. Now, in this medical team, when we think about the response that can be sent from the emergency care, they also have different devices, okay? So you can send a paramedic, you can send an ambulance with a nurse, you can send an ambulance with a doctor. These people, some of them, doctors, for example, can have access to the healthcare, to the electronic healthcare record. And then they can see all the information as well, and they can give feedback. They can feel part of the information back. So emergency care, it's actually part of the integrated clinical path 24/7. The third enabler has to do with these shared clinical records. We need some technology that will make all this possible. And this technology is the shared clinical record. This is the same graph that I was showing you before, so everybody can exactly see what happened to the patient, whether the patient has been labeled or not. And there's also an individual portal where the patient can find his or her information. In the shared clinical records, apart from the feedback, you have data on lab results, you have the usual data on diagnosis, and also you have some free text data. And that's what I think makes a lot of the difference from the typical clinical records that we can see in other parts of the world sometimes, because this free text is where you can put all these care paths. And finally, I would like to say a few words about the local agreement. So I was telling you that this whole care pathway has been designed thinking about these different local realities. Now, what's very important, I would say, in the Basque Country case or in the Catalan case in Madrid as well, but the local realities are maybe more similar because it's more urban, but basically you have to have a plan, a system, a method that would be flexible enough to adapt to these realities. And that's precisely what in the Catalan case has been done. So basically, the local providers are the ones that would work together to design a local agreement of how they want to respond to these different characteristics. There will be a meeting of the different local leaders that can be different types of leaders in different territories. In some, you might have a representative of a patient's group. In some, you might not. You will have the primary care nurse, the primary care doctor, maybe more than one. You will have social services representative. You will have a specialist of different types of diseases representative. You will have emergency care representative, maybe mental care providers as well, depending on the characteristics of the territory. That's very different. In different areas, imagine somebody that works in the mountain. There, the response might be, as I said, very, very different, and you might involve different types of first respondents than if you are thinking about the city of Barcelona. So this local agreement is based on the key conviction that the success depends on the path, sometimes more than on the protocol. And I would like to take this with caution, but it's very important that we think about the way so that we can instrument what happens to the patient. And for that, we need the functional integration of all agents in the territory. We could try to do it centralized from the central government, but that probably would be less effective than telling the territory members, hey, you coordinate between yourself, you get together, and you figure out the best way of delivering the best possible care to these patients with these characteristics. And that's precisely what is being done in many regions in Spain, and in particular in the Catalan one. So the local focus is crucial, and again, it's a collaboration with all the different members that will try to implement, that they will implement the best practices. The fact that it comes from the local leaders, I think it's very powerful, because that makes them feel empowered. And basically this plays a crucial role on the success. They are the ones that would develop the pathways that I was telling you about. Okay, they will think, of course, these pathways are then personalized at the patient level, but it will be the local leaders, the ones that would decide which are the key characteristics to take into account when responding to different situations. Who is going to be the first respondent? Is it going to be a nurse? Is it going to be the primary care physician? How are we going to organize emergency services in the territory? What are we going to do about mental care? Is it going to be in primary care, or do we have a special mental care hospital, etc.? And this agreement, it's a local, formally written agreement between all the providers. So I think, just summarizing, that this integrated care pathway, it's a way to organize all the people involved in the care process. And basically, one of the most relevant characteristics is that it has the flexibility to adapt to the different particularities of the territory. In the elaboration process, it's the local leaders, the ones that would help develop it, but basically a group of experts at the Catalan national level or at the Basque national level would set the conditions, the target, which is the objective, to take care of all this population. And then a second group of experts at the local level will use these key elements and and adapt them to the territory. And finally, this pathway would be transmitted to the central authority. Currently, in Catalonia, we have very high numbers of all these local agreements. The 87% of the regions of the local territories have this agreement. 90% of them have this agreement to respond to crisis situation, but only 29% of them, for example, have a model for long-term care facilities. So there's still some more way to go. And finally, let me finish by just showing you the final results of our research. So what we have done has been to identify, out of these very many different areas that we have, in this case in the Catalan context, which are the ones that have been implementing what the 2011-2015 health plan was really meaning, because as you know, when you put a plan, it might take some time to implement them. So the one that has been farthest ahead has been identified using different objective identification measures as Osona, which is in the center of the Catalan area. And basically, what we looked at was to see how well did this region perform in terms of two outcomes, in terms of avoidable hospitalizations and also in terms of readmissions after 30 days. To do that, what we did was to compare this region with a synthetic meaning, tell me which are the key characteristics that you think are relevant to determine chronic care. It might be the complexity of the hospital that we have around, it might be the age, the average age of the patients in the location, income, different characteristics. So we put all these very relevant characteristics there, and with them, we designed the perfect comparable hospital, which is a combination, region, which is a combination of several. And basically comparing Osona, in this case, against the synthetic, what we can see is amazing improvements, both in the reduction of avoidable hospitalizations, as well as on the reduction of 30 days readmission. These general results of better outcomes are something that we can find also in the other two regions of Spain, where very many different projects have been also implemented. I think I will stop here, because I think that's the time that I've been assigned, and I'm waiting for your questions. And I have here my two colleagues from Madrid and the Basque Country who will help us, me in this case, with the questions that you have also about their particular reasons. So you can send them, Grayson, from in different manners that you can read about. Yes, this one. So please discuss more how to link health with social services or senior day centers, primary care, things. So I will share with you maybe one or two Catalan experiences, and then maybe my colleagues would like to share some experiences in their territories. As I was saying, the experience is very diverse because we have different territorial realities. I can tell you about some. For example, in some areas, the area that we visited in particular, the social care contact person is, as I said, located in the same building as the primary care patient. There, when some patients go with their families to see the primary care doctor, in many times, the social worker would come with them. And then they would work together the best path. So we can have patients that basically are have a chronic condition that live with their wife, for example, and that would need to be taken out of bed daily. That's the only thing that they would need. The rest, the wife can take care of it. Okay, then in this case, that's what would be organized. Another thing that is being done, for example, is with patients that have advanced Alzheimer or some early mental problem. We have what we call day centers. So they, thanks or through the social worker, these patients might spend the morning or the whole day in a center with special programs for them that will help them keep their cognitive abilities. So for example, they might play cards, or they might organize social activities, they might do some handicraft, etc., so that they would work together with patients that have similar conditions. I don't know if somebody wants to share something.
Yeah, so
Anna wants to say something, so she's from the Madrid region, so I will let the seat to her and I will continue.
Just to show you one case, it's the case of Hospital Rey Juan Carlos and the social plan with the nursing homes. And this is an initiative that includes a lot of different elements of integrated care. For example, the planification of discharge and the follow-up after discharge, and also the hospitalization in the nursing homes, and a continuous communication between the hospital and the nursing homes. And the analysis of the results shows also a reduction in the avoidable hospitalizations, for example, or an increase in the satisfaction of the professionals that work in the nursing homes, and also of the patients and family that are part of these nursing homes. And this is just an example of what is happening in the different territories, not also in the global territory of Madrid or Catalonia, also in the specific territories that are at the head of the integrated care in our country.
We also have question about the cultural change that it's necessary for this to happen. So in this, we just had the previous meeting with the representative of the different regions and also with representative from the US. And what I wanted to share with you is that I think that that's true. Cultural change is very, very important, but the big question is, how do we get there? And what the three of us, and together with our colleagues from the US, agreed on is that it's very important first to have a narrative. You need a story that is convincing enough, a story to explain people why and how are you going to be doing this change, because that's fundamental, because once you understand why, then the change will happen. Another thing that it's very important is to think that we are just not providing care to this patient, but we, apart from thinking about the care solutions, the medical solutions or social care solutions, we are talking to a patient that has her preferences and her values. And this is something that needs to be completely implemented. So, and then the third element, it's very important to find your local leaders. You need to think about who is going to be driving this change. Who is the one that will start thinking about how to implement that? It's not easy to be the first one. It has to be somebody that really, really, really wants to do this. And we have all these local leaders around. So they are the ones that will maybe start with the change. And once this is done, escalating is going to be easier. Because in this sector, we have a lot of, it's going to be easier. I'm not saying easy, but basically it's going to be much easier because a lot of people in the sector, basically you have all doctors, nurses, everybody wants the best for the patient. It's just that maybe not everybody's going to be leading the change. So find the local leaders, keep the narrative, and think about what the patient needs. I have more questions. How long did it take to develop and implement these integrated care systems? And how did you get the different providers and organizations to work together to develop one system? Do you have any tips for getting started? That's a tough one. So, okay, Anna, in the presentation that in the workshop that we had a little bit earlier, she was showing in the community of Madrid all the different parts, and you could see that this is a long process. I mean, this is something that started in the plan, it's 2011, but actually it started in the minds of many people a long time before. This takes time. Change takes time. So it's not something that you would go and just do, but I would say something very important. To change this, we are talking about the structural change. In a structural need, when the needs of the society are so different, you need to make a structural differences. You can just not put patches there. You need to do something different. And for that, you need to change many pieces at once. If you just change one piece at the time, maybe what will happen would be that you will end up with a structure that will be even worse than what you had before, because you will start from this is a given and let's add the social component there. Okay, so basically it's important to think of it as a whole. And then you said, how did you get the change started? You'd be amazed of how many people are excited about that in all the countries. When we go here in the US, we shared a group with people that were really excited about that. In Europe, we have a lot of people that are very excited about that. So I would say, like, anytime you have to lead the change in any organization that's not different, find your leaders and empower them. Don't tell them exactly what they need to do, let them be and see where that takes us. So that would be my recommendation. What does that care integration mean for the funding model, payment, and incentives for health and social services? That's the key question, right? First thing, let me just tell you something that most of you probably already know, but just to emphasize that. So in Spain, care has been decentralized to the regions, and regions receive a general budget according to the population and some other characteristics. And then this general budget is assigned to healthcare or social care. So the fact that we have a general budget for one region, it's an important component. Now, of course, the funding, it's always key. We have to still figure out the best way of making sure that these savings that you might experience in the healthcare system, thanks to bringing the social system on, are appropriately shared. What I can tell you is that even though this is not finished yet and we are still working on it, I think that it's very important, first, this local component, because locally, the different parts will find the best possible way. Also in Spain, primary care patients have been, primary care doctors have been assigned a fixed amount of patients, let's say. So these are the patients that they have to take care of. And the territory has a bunch of citizens as well that they have to take care of. But doctors and social care workers receive a salary that does not depend, like it would depend in the US, on how many people you see. So it's just taking care of all these patients, and I think this helps a lot. How is training the people that are working on this integrated care services system? Thank you. That's also a very, very important question. And actually, my two colleagues shared some experiences as well with us. Training is very important. We need different roles. And there are some special directives and guidelines preparing nurses in particular, if they have to be case managers of this role. But at the end, Richard Scheffler, to conclude all this training at the end of the session where we were talking about that, he said, well, we will need maybe different types of roles that maybe they don't even exist. And I think he said, well, what do we need? Do we need managers? Do we need coaches? Or do we need coordinators? And he said, well, that probably the composition of this is closer to a very complex coach that basically will help the patient, on the one hand, feel empowered to take care of himself and herself as much as possible, to coordinate with the family, etc. So my answer to that is that probably it will not just be enough to train the ones that we have, but we might need to think about new roles that have not been developed yet. And I think that I will leave it here. Thank you all for your questions, and apologies for the questions that I could not answer. But I'm going to leave the floor to Steve. Thank you.
Good afternoon. My name is Steve Cha. I'm the director for the State Innovation Group at the Innovation Center at CMS, and very pleased to be with you all today. I think I wanted to talk on a few responses to the fantastic conversation we've been having with Nuria and the rest of the team in terms of how do we connect current efforts at CMS and the Innovation Center and put that in the context of these lessons that we're hearing from the Spanish experience. So let me walk through those pieces and where are there more opportunities. I think if there's a theme to what I'm about to jump into, the theme is that, and I think this came up in questions with Nuria, but that the financing framework and is fundamental to enabling some of the reforms that she was describing. And so I think on some level, we need to think about how we solve for that problem here in this country. We are thinking about that. And that's the key message I want you all to be hearing, that that level of transformation is closer than you think. And I think in a lot of areas and localities, we are reaching the point to really maximize the lessons that we have heard from our Spanish friends. So let me start out with our Innovation Center statute. The purpose of the center is to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality furnished to individuals under such titles. And then there's 3 bullets about the scenarios for success. Quality improves, costs the same, quality neutral, cost reduced, quality improves, cost reduced as well. That's best case. Went through that really quickly, only to make the point that there is a bullet that's not on the slide, which is quality improves, cost increases. And that is not to say that everything has to be a zero-sum game. We very much understand that there are things that you can spend more and get more from. It is simply to make the case that it is beyond the framework for our statutory authorities at the Innovation Center. And that sort of creates boundaries for how we think about some of the reforms. This is a slide that we've been using for a while. And this is the idea of, fine, we have this idea that we want to improve care and reduce costs. How do we do that? And I think this slide is really critical to us because it breaks it down into what we're actually trying to do. We focus on the way we pay providers, we focus on the way we deliver care, and we focus on the way we distribute information. And we often see, I think all of our models encompass all 3 of these. Some emphasize more one or the other. But I think it's important for us because I think it's very easy to roll forward doing one and forgetting the other 2 and think you've done something. We think you have to be thinking about all 3 of these together. And to put that in the context of what we just heard, as I said, I think we didn't hear a lot about payment transformation because I think it's such a different framework in the Spanish system. But I think we are getting there in terms of thinking about how we pay providers to better incentivize them for care improvements. We heard about, for instance, one of the pillars that Nuria talked about in terms of the individual care plans. And I think that folds into this idea of how do we deliver care differently. And we heard from her in terms of this idea of how do we identify the population and share that information with the appropriate providers. And that falls firmly into this idea of distributing information. And it's not to say that we're already doing that. It's to say that I think there's alignment in terms of the lessons that we are hearing from our Spanish partners and what we are thinking about and trying to innovate on within CMS as well. Just to expand on those 3 buckets, this is a difficult to read slide, but if you see those on that left-hand column, the 3 focused areas: pay providers, deliver care, and distribute information. And I think we have, as you can see, the most work going on that first row. And I think, again, that's because one of our principal challenges in this country, I think we use this line a lot, is we need to first create that business case for transformation. We need to create that business case to support those lessons that we just heard about from our Spanish partners. How do we think about the payment strategies? And so this list is familiar to folks who have been tracking the Innovation Center. We have our accountable care organizations and a lot of models under that bucket. We have a lot of focus on primary care transformation. How do we rethink how we're delivering primary care? Bundled payments, Medicaid focus, dual eligible, and Part C and D. A lot of efforts to rethink how we actually pay providers. And again, that is a fundamental task we need to think about. But it's not enough, and I think that's the lessons that I heard from this morning and from today as well, which is how do we think about delivering care differently? We need to think about both how do we support providers to understand how transformation happens, and I think that happens under some of our Partnership for Patients and Transforming Clinical Practice initiatives, our Healthcare Innovation Awards that have already happened. And in particular, I wanted to highlight the accountable health communities, because as I listened to Nuria speak, I heard this theme time and time again about how do we connect healthcare to that broader issue of health? How do we really transform a healthcare system organized around providers into a health system organized around our beneficiaries? We are not all the way there on that journey, but certainly the accountable health communities is one of our steps towards getting there. I'll go into the state innovation models in a second into more depth, but the final bucket really being distribute information. It's a key factor for the success of our programs. How do we think about those ideas of how do you share information in real time with the right people at the right times? This is a quick slide to say we've been in existence since 2010. We've touched over 18 million beneficiaries, over 200,000 providers participating, and that's growing every month as we continue to expand our programs. So we are in a very short period of time in the healthcare space. I think we are continuing to push that bounds in terms of how it means to improve care and reduce costs. Let me talk for a minute about some of the state-based programs. And I think that has particular relevance for trying to put the Spanish experience into some context. What we see, and you saw from my very busy slide of programs across the Innovation Center, we have an enormous number of programs happening in the Medicare space. And we are innovating on a national level with partnering with providers across the country. But when we think about that highlighted pillar of local agreements, when we think about that opportunity to align a geography with a healthcare system, I think that's where the state level alignment is so critical. And I think there are two reasons. One is on the slide, which is that we think it's a key level to reducing provider burden. And we hear that time and time again. As the Innovation Center has expanded more and more programs, we constantly hear, okay, but there's too many things I'm trying to do. We have multiple initiatives, from the accountable care organizations to our patient-centered medical homes to our bundled payments. And some of those are happening in multiple payers at the same time. So those efforts happening under Medicaid, under commercial payers, under Medicare. We get this multiplication effect in terms of providers trying to do 1, 2, 6, 8 things all at the same time. And that creates real burden. And when we partner with our states, we can think about, and it doesn't have to be states, I think it can be geographies. We can think about what that multi-payer alignment looks like across an entire geography in a way that we're trying to engender alignment across the country. And we are still engaged with that effort, absolutely. But when we get to a state level or a regional level, we have the opportunity to say, not just here's in general the kinds of metrics we should be using in a philosophy or general rule of thumb. We can get to the same metrics. And we're seeing that from some of our state partners. And so when we can align that cacophony for providers, we enable something else, which is not on the slide, which is the idea and the opportunity to really think about the population of a community and connecting that directly to the delivery system for a provider community. That's the exciting part, is both to reduce the provider burden and at the same time really transform the efforts and be able to connect to that health mission that we all have always been seeking. Skip the slide. Here's one of our major efforts to try and think about this. This is the state innovation model. And we supported 38 states, nearly 2/3 of the US population. And we invested nearly $1 billion in partnering with states to invest in local state-led health system transformation. And so when we hear some of those ideas about what local agreements might look like, what local data systems look like, there's a lot of transference and relevance to the state innovation model experience. And so we've seen in round 1, 19 model design, and in particular 6 model test states. And those test states between the 2 rounds are in green on the slide. 11 model test states, again, those test states had a a significantly larger award, and then 21 smaller design awards. So when we think about, in particular, those green states, and to some degree the purple states, although it's more challenging because of the size of the award, we've seen amazing efforts towards thinking about what transformation could look like. And here's some of the work that our state partners did. And I just wanted to highlight a couple examples, again, to parallel what we heard from the experience in Spain. So I'm going to start at the bottom of the slide. Third up from the bottom is this concept of stakeholder engagement. This idea of local agreements, this idea of how do you actually partner across the state. This is not an official evaluation standpoint. This is from someone who's led these efforts. I think that's probably been one of the most critical pieces to thinking about how successful we've been in this framework. How do we think about partnering with stakeholders and governance at a local level to create the impetus and the momentum for everything else that our states were engaged in? And how do you also work through those kinds of lenses? And I was interested to hear that idea of really taking national trends and how do you make that local. We're seeing that all happening in our stakeholder process as well. We think about the national issues behind behavioral health and physical health, and how do you integrate those? And how does each locality think differently about that? It's a really exciting effort. Opioids, and how do we think about that? In terms of the health information technology, how do we share real-time admission discharge transfer feeds? How do we think about some of that work? Looking at the clock, let me just end with the slide here, which is really to think about the second bunch of body of work that our division does is not just the State Innovation Model Award, which are, again, cooperative funding agreements with our state partners to help them design and launch innovation. Under this division, which we call our multi-payer model work, we are providing custom state-specific Medicare flexibilities. So I think a lot of people around the country have been engaged in flexibilities under our Medicaid program. And beginning in 2014 with Maryland, we began to do something we hadn't done before, which was to offer waivers to an entire state's Medicare program. And in return, what we asked for was state accountability on reaching scale, meaning we wanted to say, look, if every payer is in and Medicare is the one not at the table, that's a problem and something we should be engaged in. We didn't want to be just experimenting on Medicare across the entire state alone, but let's be part of solutions that are locally driven. So scale targets, meaning everyone in a state across payers and providers are in. All payer financial targets. We have no interest in saving money on Medicare and squeezing the balloon and having that float out elsewhere. And then, of course, our Medicare financial targets to generate cost savings to Medicare. And then finally, I think what I talked about when I transitioned to state-based reform, this idea of population health targets. How do we actually leverage this very unique tool, this idea of geographies, to transform health for an entire population? That's, to us, the exciting part, to really achieve that alignment and achieve that kind of transformation in health. This financing formula has been key to all of these interventions. So in Maryland, what we began with was hospital global budgets. And again, I think I wanted to underscore that what we just heard. In Spain, the hospitals are in fact under a global budget, although it's more than the hospitals there. In Maryland, we began with just the hospitals. And as the Secretary of Health said at the time of launch, we've now made it more profitable for a hospital to keep someone out of the hospital than to put them in it. And that was a key part of what we were trying to do. In Vermont, it was not a global budget. It was really trying to say, what if we bring every provider and the payers under a common accountable care organization framework? And once everyone's trying to pull in the same direction under this custom Medicare model, which aligns with Medicaid and private insurers, and the providers have more capability to do things, can we, in fact, and we set goals of not just reducing rehospitalizations, but let's reduce the number of substance use deaths across the state and suicides. Let's think about not just disease management, but prevalence of diabetes and hypertension. With this expansion across the entire state, how do we really integrate those efforts between health and healthcare? And then Pennsylvania was an attempt to take that same idea of hospital global budgets, but adjust that for rural hospitals. And I think this body of work in particular is going to grow. We know that rural hospitals are under enormous pressure. How do we think about the kinds of service delivery transformations that are possible under a global budget? How do we think about the lessons in terms of that we heard from our Spanish partners about identifying populations, identifying individual care plans, sharing that information under that kind of umbrella in a rural area, and what does that look like? that's the exciting part for us. With the last couple minutes, I just wanted to, as I said, close with this slide just to say a couple things. Number one, that transformation, as I said in the opening, is closer than you think. For so long in the Medicare program, we've seen providers moving ahead in terms of trying to think about new ways to deliver care and pulling Medicare behind them in terms of thinking about it. I think since the advent of the Innovation Center, we are seeing transformation. And in particular with partnerships with our state partners, and we're going to hear from Marianne in a second, payment is transforming. And in particular in certain geographies, we are seeing transformation that is leapfrogging the ability of providers in terms of the delivery changes we've seen. And it's exciting to begin this chapter where a payment is no longer the barrier, but now an enabler. And now we open up the question of, okay, now what can we do to follow in the footsteps of our international partners? So I want to close with some final concepts on what Maryland's next phase would be. And these concepts are what the state has proposed to us. It's on the public record. We are still in the process of contemplating that, and we have not cleared anything yet. But I think the ideas are interesting to think about because I think it takes a hospital budget model beyond. How do you think about opportunities to collaborate and gain share with, say, specialists or post-acute care setting? And that's one pillar to build on the hospital global budget. How do you think about a whole new framework for primary care that builds on those lessons? How do we enable that across the entire state? What do we need to do to enable small practices to participate? What do we need to do to enable community health teams to begin to get into where our beneficiaries really are? And how do we strengthen that accountability, not just for healthcare quality, but for health outcomes across the entire state? We're not there yet, and so I'm excited to continue that conversation with our Maryland partners. But I wanted to give a teaser because I think we're in full recognition that the hospital global budget is not enough, and we need to think about what we're hearing from international partners to think beyond, to think about the transformations that are necessary. Let me turn it over to Marianne.
Thank you, Steve. Mary Ann Lindeblad, and I'm the Medicaid Director for the state of Washington. And today I just want to do a little follow-up on what Steve just talked about and talk a bit about a couple of the successes that we've had in the state of Washington around innovation and where we are. But before I do that, I just want to, oops, went the wrong way. I just want to give a little context about the state of Washington. We have about 7.2 million lives. About 1.9 of those million lives are in Medicaid. The agency I work for, the Healthcare Authority, does purchasing for the Medicaid program, but also for public employees. And in 2020, we'll be adding school employees to that. So you can imagine with that kind of purchasing clout, as we purchase soon to be for over 2.5 million lives, and more than the $10 billion spend that we have right now, it really gives us some leverage as a purchaser in how we design and pay for care in our state. And right now, the major focus in our agency is really about really improving the health and the lives of the people and our communities. And what are the tools that we can use to really move the market and accelerate transformation through our value-based purchasing, and through other investments that we've made through a couple things that I'll touch on with some SIM money. Steve mentioned the SIM. We were one of the round 2 grantees, and we received a Medicaid transformation waiver in 2017, and really, again, helping us advance our delivery system reform. So just just a bit of a model of what we're looking at Healthier Washington through innovation. With a focus certainly on purchasing, so value-based purchasing. We want to get away from fee-for-service and look at other vehicles such as capitation, subcapitation. We are currently a big managed care state for our Medicaid population. About 85% of those enrollees are in one of 5 managed care plans. So we already use capitation to our MCOs, but to make sure that they're passing that down through subcapitation and other payment models. We're initiating some bundled payments, looking at various ways of sharing risk, and we have performance withholds within our managed care contracts. Also looking at how we build out healthier communities and through regional collaboration, which we call our accountable communities of health. And I'll talk a bit more about that work. later, we're also looking at how do we focus on whole person care, and you've heard about that certainly from the Spanish experience, and how do we do a better job of that. And one of our major initiatives around that is really to integrate behavioral health and physical health so that we really look at people, how we deliver services through a whole person approach. So the different ways that we're looking at getting to a healthier population is, again, looking at the ways we change, looking at the ways we pay for care and how we change that and really focus on value-based. Using data more effectively, using data from the standpoint of data-driven decision-making, data at the community level, data that we use to decide things like benefit design and purchasing care that is evidence-based. Recognizing that we need to engage individuals and our members, our beneficiaries, and their families more effectively. Again, you heard a great deal about that from the Spanish experience in terms of getting members of families and individuals doing their own and being part of their own care plan and being more engaged. Also looking at how we integrate funding more effectively, not just the funding from Medicaid, but also funding from other resources that help pay for care. This takes significant leadership support to do this kind of work. I talked about physical and behavioral health needs, looking at that collectively and collaboratively. It requires a significant amount of communication across the delivery system, across the providers, across the community. And we certainly are seeing much more of a blending and a melding of the cultures of those that are engaged and involved in the healthcare delivery system. I think probably many of you have seen this slide, but just recognizing that health is really more than healthcare. About 40% is related to socioeconomic factors, another 30% are related to behaviors, 10% about physical environment, so only about 20% is influenced by healthcare. So for us at the Medicaid program in Washington, looking at 3 major strategies, and this is supported through a variety of efforts, but primarily our Medicaid transformation waiver that we got, but really looking at some different ways of how we deliver services and how we transform the delivery system by, again, better measurement, looking at things like the social determinants of health. How many people are homeless? How many people have an incarceration history? Looking at adverse childhood experiences and deliver programs and services around that. And engaging delivery system and providers differently, using community health workers more effectively than we do today. And looking at ways of making sure that we're using our providers most efficiently and working them to the top of their license. A couple of things that we have, again, coming to us through our waiver is looking at a different way of delivering long-term services and supports. We certainly, as we all know, you can hear it talked about as a silver tsunami or the aging population, but we are an aging population, and we have to look at a different way of delivering services to folks that need long-term care and family supports. That's certainly one of the biggest drivers of Medicaid is the long-term care delivery system. We also know that many of our families want to take care of a family member in their home. They don't want to put them in a long-term care setting, in a nursing home. They want to support them in the community. And so we have now started a program of delivering long-term services and supports in a different kind of a way. We had a small pilot looking at how we could support unpaid family caregivers. Now we've actually been able to expand that through our waiver, where individuals can get respite, they can get some DME and an array of other services, and we do it in a couple of different ways. One, to families that are actually also eligible for Medicaid, but choose not to, they don't want to take advantage of the full array of services, but giving them some supports. Again, respite is really critical to that. Or individuals that are at risk of becoming on Medicaid. So they don't have to spend down their money. They can keep their money longer. They don't just become impoverished to become on Medicaid. And so again, supporting those families with things like respite, equipment, wheelchair ramps, a variety of different services that can be provided sort of outside the traditional delivery system. and foundational community supports, which is a program that we just started in September of excuse me, last year. And it's to help individuals with really complex healthcare needs obtain and maintain housing and employment. It doesn't pay for the housing, it doesn't pay for the salaries, but it pays for the kind of supports individuals need to be able to stay in their house or keep a job. I mentioned I'd talk a little bit more about our accountable communities of health, and this is critical to our vision and a really major component of our transformation vision, and really bringing together cross sectors of the community that can really work together to address healthcare needs through regional collaboration. Tribes, our managed care organizations, our provider communities, social services, other community supports, local public health, counties, a whole variety of individuals coming together to really help us think through about what are the needs of their community, engaging stakeholders, engaging the provider community. And really, this is key to helping us integrate our physical and behavioral health services, improve the way that we provide those services, and again, really transform the Medicaid program. Just again to mention, this is really about health reform and looking at both cost and quality. And we know that the Medicaid program is not going to survive on the trajectory it is unless we change the way that we deliver services. I think just in terms of, excuse me, whole person care, looking at, again, people differently than we have team-based care, more individuals that are engaged and involved with the member, better communication, better coordination. Data. We know that data is necessary to do the kind of measurement that we want to do and be able to track and trend our members' registries so we know services that individuals have gotten or have not gotten, and again, connect people to their community. So some of the things that we are looking at to measure as we move forward is looking at ways of measuring health status, and particularly on the behavioral health side, and focusing on recovery and resiliency. Making sure people are participating in meaningful activities, employment, education, reductions in ER, hospital and crisis services, looking to reduce involvement in the criminal justice system, getting people more engaged as they come out of jail, particularly individuals' mental health services or substance abuse needs, to get them the treatment they need so they don't go back in. And also looking at a variety of ways of starting treatment for individuals as they leave the criminal justice system, and also increasing housing stability, and looking at folks coming out of the psychiatric hospitals to make sure that they have adequate services as they come out. One of the programs where we've had great success in has been our Health Home program. And this is something that we did even prior to our waiver. And this really was a focus on the highest needs, highest risk populations that we have. And we used a risk stratification methodology to identify those individuals in the community, sort of that top 5%, and looking at an array of services that could really help them, again, stay in as part of the community. Typically, a number of these individuals are dually eligible, have both Medicare and Medicaid, and they're individuals that have some really high needs and are at very high risk for rehospitalization, emergency room use. So services that they are provided is a set of comprehensive care management services, care coordination, health promotion, transitional care planning. So as folks are moving in and out of the delivery system, moving from hospital to home or hospital to long-term care or to nursing home, providing family supports and individual supports, and looking at referrals to community and social services. It also is something that really engages the member. So the member is there as part of developing their own care plan. And this has been a program that has been very successful, and we have seen that it really has changed lives for folks. It's kept people in homes when they may have ended up in a long-term care setting or back in a hospital. In a demo that we've done with CMS, we've actually saved an estimated saving the Medicare program over $67 million over the first 2 years by this program. And we got to share in those savings, which even made it more interesting for us to actually participate. I think just as payment, as you've heard already mentioned, that it really does drive system transformation, and the way that we pay care for today, it's fragmented, it's not coordinated, people are left out of their decision making, they're not involved. You heard again a lot about this from the Spanish system. Great deal of variation in the system, and there's really very little financial accountability, and that is certainly changing. That is absolutely changing in the state of Washington as we move towards more integrated care, more coordination, really engaging and activating individuals into their care, and having a more standardized performance approach and performance measures that are tied to financial accountability and member outcomes. So just really quickly, a couple of different efforts on our public employees side. We are contracting with some accountable care programs where those programs have both upside and downside risks to incentivize clinical quality, excuse me, total joint replacement bundles. On our Medicaid side, we now, it actually is up to 1.5% of a premium withhold, and the plans, our managed care plans can earn that back by performing in certain ways on their quality and value-based purchasing arrangements. Our behavioral health integration that we're moving by January of 2020, the full state will be integrated across our delivery systems. We have 2 regions of the state currently integrated, and we're already starting to see some successes out of those regions in terms of decreased hospitalizations, lower incarceration, and some other performance measures are trending in a positive way. We are now exploring a value-based purchasing model for rural settings, and again, tying our value-based purchasing goals to incentive payments. So as I think about this, and just to tie it back to what we've heard about today with the Spanish experience, is really about improving care coordination, our chronic care management, a focus on primary care and our high needs and high risk patients, delivering care at a local level, more of a regionalization model, better integrated care, and really starting to integrate the social determinants of health. So from a Washington perspective, really looking at how we transform, how we purchase care, how we align our business with the national movement to get away from fee-for-service to value. We have great opportunity through our Medicaid transformation demonstration through 2021, and again, with our goal for better care, healthier people, and lower costs for folks in Washington.
Well, good afternoon. I'm Paul Wallace from Academy Health, where I'm a senior scholar, and it's really my opportunity now just to share a few thoughts, and they're really based on both my experience here in the States, but particularly on the opportunity and the pleasure, really, of being able to visit Spain last year along with the study team and do a thought with the team since then about how to summarize results, and also from hearing Steve and Mary Ann's input today about how this is not just something happening in Spain, it's actually happening here. And so I wanted just to share a few cross-cutting comments that I think get to kind of where we've gotten to, but where we need to also be thinking going forward. What we share really around the globe is this challenge of how do we pivot from healthcare systems that have been designed to manage acute illness to a framework and a system and a range of supports that will be available for people as they encounter and live with chronic conditions for many years. I think key to this has been the ability to identify who's at risk, and we traditionally think about the technical exercise of risk stratification, but I'd like us to reframe that a little bit and think of it really more as sort of a social intervention of being able to think about what can we do to personalize care, and to realize that the goal here is to support people as they transit through care. We've historically in medical care thought a lot about patients. Patients have diseases. when we think about people, people live lives. And those lives go on 24/7. They include all the time that you're not in the physician office, but they include the time with your family. They include the time in your community. And also thinking about people rather than as patients allows us to also better recognize their social context. And also importantly, to recognize their preferences and values so that the plans that we develop with them, not for them, can both reflect and respect what their preferences would be in terms of the care that they receive and the care that they encounter. So I think a huge opportunity here is for us to even reframe our thinking as part of this pivot from how do we risk stratify and come up with the sickest people to how can we actually personalize care for the folks that could most benefit from the range of services. And I think you're seeing some wonderful examples of that both at the federal level of how the Innovation Center is investing, but also at the state level of how that investment is translating into real help for real people. I think it's also important though to drill down a little bit and think about what are some of the supports that are necessary for that. One of the challenges that Steve talked about is payment and payment reform. I think we need to recognize that a lot of what's been accomplished in Spain has happened in the context of global budgets, at least global budgets for healthcare, and the ability to think about how global healthcare budgets can be integrated in with social care budgets. And I think that that's an important ideal for us to strive for and think about how can we align incentives in a way that global budgets enhance. It doesn't necessarily mean the only way to do this is with global budgets, but it certainly sets the bar for what we need to be aspiring to as we think about overall design. The other thing that strikes me as we think about global budgets and larger longitudinal schemes for financing is that it also drives us towards system solutions and recognizing that there's a lot of interrelated moving parts. And when we change any one part, it is going to have to be reflected in how we think about all of the other parts. I'm often reminded that when we think about continuity of healthcare over time, the only person who consistently experiences the care of a patient across providers, across communities, across institutions is the patient. And if we aren't designing around the needs of the individual, we're going to miss. So it does take system solutions. It's the challenge of one-offs in that they often will solve one problem and create 6 others because they didn't actually anticipate how the system actually works. So on a sort of intermediate level, we're recognizing that how we think about how we're paid for our services and the incentives that are involved is really critical. Really thinking about more granular enablers though, all of the solutions that we've seen today also to some degree are both enabled and depend on information technologies. The digitalization of data so that isn't the rate limiting step in how we can actually think about doing analytics, novel analytic frames using digital media for communication and engagement. So I think that technology is a very important component to this, but the value of the technology is not the technology itself. It's that it allows us to think about doing things differently. It's the same way with payment reform. If all payment reform does is allow us to write a bigger check for the same thing, I'm not sure we've actually accomplished anything. And technology has the same challenge that if all we do with technology is just figure out how to automate our current processes, we've really missed the opportunity. But I think what we're seeing here has happened in Spain, thinking about how the electronic health record can be accessed across the whole range of settings wherever an individual may come in contact with care, the kinds of things that are happening in other places tell us that technology, in addition to actually doing things technically, can engage people in conversations. It's the what if discussion and realizing that once you put a technology in front of people, they can begin to contemplate and ponder, what if I actually did this and what if I did that, and test hypotheses in that mode. The final comment I'd have is, and maybe I'd also encourage everyone to thinking about your questions for Steve and Marianne and Nuria and the others as I just close here. But I think leadership is the theme that has been prominent in all of the different discussions, but it's a nuanced leadership, and it's a leadership of creativity and ideas, but it's also importantly a leadership that involves delegation and acceptance that that different areas will perform differently. Creating care paths is providing guidance, but it's also creating the responsibility of those using the care path to appropriately adapt to their own circumstance. And so leadership has both that conveyance of authority, but it also has creating accountability and also agency to think about how good work can be done. And I think that also helps us hedge our bet, frankly, to observe well and see what works. I guess it also goes to Mary Ann's final comments too about measurement. And I know Steve and others have thought a lot about this too, that we're not going to know what works if we don't actually observe and test what works. And so it's important for us to be thoughtful and rigorous in how we do that, but it's also equally important that we spread information as soon as we get it. So in summary, I think the things that have really struck me is this pivot to personalization, thinking about how we can create incentives, perhaps idealized by global budgets, to have people thinking on the same page, and then recognize that there are these enablers around technology, how we create relationships, but particularly leadership, that are really fundamental to this, and thinking about how those exist in your own community now, what you should be doing in order to enhance those, and where your opportunity may lay. So thank you very much, and I'm gonna, I think we have some questions that come in, and maybe we can pass those around to whoever would be the appropriate respondent. Did you have one for Steve? Steve, I'll let you go first.
So the first one, how is social care component paid for, or better, who pays for the social care component? Hospital global budgets are surely for healthcare services, right? So I think that's accurate. I think the goal from at least the Innovation Center perspective is how do we really drive towards the fundamental goals we all share? We all say all the time, we want better care, better health, smarter spending. I think that's becoming something that has become a truism to a certain degree. And the question is, how do we get there? We're actually getting to the better care and the smarter spending angle. I think it's hard to get to the better health. A lot of our programs sort of try to think about it as, well, if we're improving quality, that is improved health, but we need to go further. So I think the question there is, if we have a hospital global budget, how do we drive towards incentivizing for health? So let me give you one example. In Pennsylvania, in the rural hospital global budget, it's not a huge piece. I'm not going to pretend like this is a significant piece of the model, but the hospitals are at risk for their global budget. I mean, that's what a hospital global budget is, and just the hospital spending. But what CMS said was, well, let's think about total cost of care. And if you can reduce total cost of care, maybe we would share some of the shared savings with you for the total regional total cost of care, because that's in our interest. But only if and only if that's done in the right way. So what we have as a policy there is the savings on total cost of care can be shared with the hospital if we transform health for the population, if we achieve reductions in those substance use deaths across the rural region. So it's a way to begin to think about, and I think basically what we're trying to do is find some way, not to use technical jargon, but to find some way to have what we call upside risk for hospitals and health entities, to put some incentive for them to really improve health in a way that is financially sustainable. It's not easy because it's a very narrow dime, but that's sort of some of the ways we're trying to think about that.
And I think I would just add to that, Mary Ann, and just thinking again along the line of what Steve was saying, you know, if we can save, so if there is actually savings accrue. So in our waiver that we have what I mentioned earlier about supported housing and supported employment, these foundational community supports. If we're able to make investments in those, I mean, this is one of the things we're trying to demonstrate within this waiver. If we're able to make those kind of investments, will that save the healthcare delivery system? So perhaps 5 years from now, there would be an ability directly to make certain investments in some of the social service related activities that will actually offset our Medicaid costs. So that is part of our demonstration and one of the things that we hope to prove, because we do believe that if somebody has a roof over their head and has meaningful activities, that there is evidence out there that it reduces hospitalization, it reduces ER visits, and people ultimately are healthier.
Quick one. What is SIM? Sorry, I skipped through that probably too quickly. It's the State Innovation Model. And so this is a program under the Innovation Center Authority to create partnerships with states. And again, about $1 billion, nearly $1 billion in partnership financing between the federal and state government to promote and accelerate state-based reform.
I do want to talk about this one. And follow up to, I think, what Steve and I just talked about. That is to mean that the cake is actually not changing, but what is changing is how big the slices are for each provider of care.
Depends how you define how big the cake
Yeah,
is.
that's true. That's true. But I think it really is about, how do we use the dollars that we have more efficiently and more effectively? And by using more evidence-based, paying for care that does provide value, incenting providers differently than we do today, that there ought to be an opportunity to save. And I think we've demonstrated, like the example that I gave with our health homes program, we actually have saved money. We've saved money to Medicare, we've saved money to Medicaid. And those dollars, it could be reinvested in other sorts of things than actually saying we need to make the pie bigger. The pie is quite large. It's, are we spending the pie most efficiently?
And I think this goes back to that's why I put up the slide about what the Innovation Center authorities are. It seemed like very boring statutory nonsense. But the point is that, again, I'm not on the personal belief that everything that costs, everything has to save money. I understand that there's a perspective that sometimes good things cost more, and I understand that. But it is not within our authority to really engage on models like that. I also think that there are a series of interventions and ways to work between social services and healthcare where we can, in fact, lower costs. I think about some of the modeling around opiates. I think about some of the modeling around maternity care. I think about some of the modeling around asthma care. The list goes on and on. It's specific tobacco. It's specific modalities where if we can think about really working together in a new way in some of these settings, we can, in fact, provide return on that investment. And so, Marianne talked about the work Washington did, but, I think about Massachusetts really saying to the ACOs, part of your payment has to go to community-based organizations at the start, but then I'm going to remove that requirement after a while. And then the idea is let's jumpstart that relationship, but that has to demonstrate value on its own merits after a time. And I think that's an interesting way to approach that. And we're seeing Minnesota, Oregon, Colorado, a lot of these states really trying to think about how do you think about, yes, within the same pie, to be honest, but how do you really think about investing that in new and innovative ways to deliver better outcomes for our beneficiaries and take these ideas of who the entity is it a healthcare entity, is it a health entity, is it a social service, and try and find more flexibility there. That's been a big piece of the innovations lately. Sure. So any thoughts about how we might be considering using technology for providing care differently? Not thinking about information exchange, but new ways of providing proactive preventative care that empowers patients through technology-enabled care services. So this is something we were just talking about downstairs, and I think a lot of ideas around the table, certainly not a CMS position officially, but absolutely. I think that there's absolutely room. The more we go towards, whether it's global budgets, whether it's new and enhanced ways to partially capitate primary care docs, whatever it is, create that flexibility to move away from the 15-minute visit and create that flexibility and the financing streams and secure the financing streams so that if you see someone through an app and maybe it's easier and shorter for you and the beneficiary, that you're not penalized for doing something that both you and the beneficiary want. We're not there yet. I'm not pretending like CMS has opened up all the doors on this. But certainly when we're in some of these global budget arrangements, we get into a space where a lot of these questions start to be, I think, as Paul put it, what if? And I think that's the right question to be asking right now. And I think that was my message of saying transformation in payment is actually accelerating quite rapidly. I'm sitting here, I'm a primary care doc, but as a CMS official saying, this is not something CMS should define for the community, but primary care docs in the community should say, here's the new model that we should really be piloting. Here's the new effort we should really be piloting. I think that's exactly the right way and direction that I hope we can continue this discussion.
Yeah, I think certainly e-consults, telehealth, things like that will really make services more available, particularly in rural areas or where there's problems with access. I also think that in the home and community-based world, that more opportunity to use technology to help keep people at home, be able to measure certain conditions more effectively, and just be able to use technology in ways that you can monitor patients from afar as opposed to having to bring them into the doctor's office. So I think some real opportunities there. I think that's
that's our time.
And that's our time. Thank you.
Steve, I'm going to turn things over now to Steve, and he's going to give us our summing remarks.
Great, thanks, Paul. It's been a great day here. I'm Steve Chartel, and I'm Professor of Health Policy and Management at University of California, Berkeley, School of Public Health, and also the Haas School of Business. I also at the university direct a Center for Healthcare Organizational and Innovation Research, where we wrestle with some of these questions. It's been a great day. I'm going to try to give you all that are still on the line a bit of an action plan to go forward. And maybe what we started off the day, or I did at least, and it underscores what we said in the webinar so far with a quote I remember from John Gardner, who years ago was Secretary of HHS. And he made the comment about most organizations have structures that address problems that no longer exist. So think about that in terms of your own organizations, whether or not you are still really organized to deal with problems from the past. An acute care system, we have emergency departments now for that, but largely we're dealing with how do we keep people well? How do you keep the population well? How do you deal with chronic illness? So I'm going to do two things in kind of wrapping up our day with you today. And that is one, to suggest 4 or 5 areas of innovations that here in the United States we can undertake in a generic sense. The particulars, of course, will vary community to community. And secondly, maybe a way to think about how we go about making those innovations. So the first one, Steve Cha has just really underlined in a beautiful way, and that is payment reform. But not piece by piece. We need to get to multi-payer reform, where CMS is beginning to push in that direction. And ultimately, I think global budgets, however we creep up on that. And part of the challenge here that you will face, that we all face, is managing the pace of change. Managing the pace of change. And the people I talk to at CMS and the local communities, they're facing that every day. You need to go fast enough. For many, we're not going fast enough, really. And for others, they're saying, wait, slow down, or you're going to blow the whole thing up. And that's going to vary a lot, state to state, region to region, and market to market. But you have to be sensitive to managing the pace of change. But where you see an opening, go for it. So I think until we get these aligned incentives, such as they have in Spain and much of Europe, in our own way, unique way in the United States, different kinds of global budgets, capitation, et cetera, it's going to be very difficult to do some of the other innovations. So payment reform will continue. Secondly, a second area is how we link the healthcare system to the social determinants of health, cross-sector. You've heard Marianne talk about accountable communities for health. We had conversations earlier today about that. It's very challenging to do. There's data exchange problems and so forth. Who's going to be the integrator, kind of, to bring people together, these different groups, in terms of common language, common understanding of the problems. It takes time to build trust. But I encourage you to develop action plans in terms of forming these effective partnerships that are beginning to develop. Third, and I think Paul alluded to it, is incorporating these new marvelous information technologies that we have that can actually assist in this regard. And the electronic health record, yes, but also the digital applications that are available now, and reaching out to rural populations and telehealth as well. But again, the point that was made earlier, none of that really matters much unless you first decide, working with your community, what it is that's going to keep people healthy. And then these rest are just tools that get behind that. So you need to figure out that first and then turn to the tools that are available. A fourth area is going to be around patient engagement, true patient engagement. Some recent research we've done with the Patient-Centered Outcomes Research Institute, looking at a couple thousand patients with cardiac disease and diabetes. We used Judy Hibbert's patient activation measure, 13-item scale, well validated. We found out that those patients who also had a mental health comorbid condition, such as depression, and if you have a chronic illness, usually you're pretty depressed as well, that those who are in the upper quartile, they were really engaged in their care. On the social functioning, patient-reported outcomes we measured. We measured physical outcomes and we measured emotional health. But on the social reported outcomes, scored 4 times higher than the less engaged patients. So this whole area of how you really engage patients, motivational interviewing, what really matters to you, not what's the matter with you, but what really matters to you, what's going on with your life, is a ripe area for innovation. And finally, we're going to need new organizational forms that we even haven't thought about yet. A lot of virtual organizations, a lot of ways of engaging practices that are small. I think CMS with their transformation payment initiative and performance initiative is making some strides in that regard. So what are you going to be doing in at least those 5 areas of innovation? And let me kind of wrap up then and suggest 4 buckets or ways of thinking about the innovations you might be undertaking. And I kind of group them into 4 buckets of strategy. What are your strategies to do this? What kinds of cultures do you need to reinforce this? What kinds of technical expertise are you going to need? And then what kinds of structures? And by structures, I'm going to emphasize not bureaucratic necessarily, but learning forums. Think of the structures for learning, right? So strategically, what really matters? I can't tell you how many organizations I visited where, oh yeah, you know, integrating behavioral health into primary care, I'll use that as an example. That's really important, that's a priority. And then you look at the budget, the dollar flow. Where is it going? It's not there, or it's there in a very minimal kind of, well, that's going to cost money, you know, we don't have enough psychiatrists or social work. Well, you know, what are you going to do about that? So the point is often the rhetoric or the realization hasn't made the action yet in terms of the allocation of resources. So what's really strategically important culturally is the culture really reinforce it. What gets rewarded? What's it like to work in your organizations, right? And so this thing about linking with social service agencies and so forth, is that really important? And in what ways is that communicated to the people that are working on those kinds of issues? So the culture needs to reinforce the strategy. You do need the technical, you need the training and the training that goes with some of these changes that are needed, and the information and the data systems, et cetera. So workforce issues and the technical issues of skills training, very important. And then finally is how quickly can we learn, the forums for learning. I remember a number of years ago, I visited an organization in the Midwest part of our country where they had a very interesting way of transferring learning. Now to begin with, they had an organizational forum that had that potential. They were a health system. They were an integrated health system. So they at least had, you know, units kind of on the same marching orders that could transfer. But what they did is, for example, integrating behavioral health into primary care, they would try it out in one part of their community. And if that worked there, the idea was the team, not the individual, the team got the reward. In this case, I think it was around $5,000 actually for making that happen. They had their outcome measures. But guess what? They only got 50% of that if they made it work there. The other 50% they only got if they would coach the other unit then, the other unit that they were involved with, or the other hospital in the community or the primary care center, to help them adapt it to their setting, but then to get the same, you know, then they got part of the rest. And it went on, and finally it dissipated until they kind of had covered the area, so to speak. So they were very creative in using these financial incentives to transfer learning quickly through this kind of step-down funnel kind of method. So these are some of the things I think that may help us think about as we undertake some of these innovations. Alignment is really important. The individual, skills and motivation. The group level, teamwork, coordination, right? The organizational level around strategy, managing complexity, removing unwarranted complexity, which is waste. Not only is it inefficient and costly, it's also an opportunity for error as well. So, and then the larger political level where Steve and others operate, of course, is aligning the political environment also. So you have to work this across these different levels. So in the last minute or two, I just want to thank everyone for being on the line here. If you have follow-up questions, we can address those. The materials you've seen here will be made available as well. And there is this old saying about if we're not near the goals we love, We love the goals we're near. I don't know if you've heard that, but I think we're at that stage of the day where we're near some goals and we're going to end it there and declare victory. So wish you all well. I hope you got some ideas you can run with tomorrow. Take care.